Dr. Soon, come. Let's go. So, yeah, but so,
Please
common,
have-
yeah.
This
So,
is a common atrium.
yeah, common atrium
The
and
loss
common
in the
APC. However, so it is difficult to say it is possible to close or not from the ventricular side. It is better, so from this one is the atrial side. And usually we decide, so it is possible to close, to make a septation or not from the atrial side. And the size of the atrioventricular valve, and if we can divide the two ostium, so depending on the all of the size, and yeah, this one is large,
Yeah.
large one, and this one, that's the one. Okay, I can see. Yeah, this one, and this is the left ventricular septum, and this one is the anterior bridging leaflet, and another side is posterior bridging leaflet. Usually, so take this. Usually, septation is coming here. Yeah, and this one. So it is possible to take this one.
I see.
And this one.
Okay.
Yeah, if like that, it's better. No. It's better. So. Take this one. No. So this by hand. Yeah, opla. Yeah, that's good. And take this one here. Yeah, that's good. And you can see, this is left side orifice of the common atrioventricular valve. And if we can divide reasonably between right and left, and close here, and if we can make a reasonable orifice here, we can divide it. And this one has a lateral leaflet here. Yeah, lateral leaflet here. And the lateral leaflet is maybe reasonable size.
Okay.
One third was, and so you can see, another one is here. Now, back side of this anterior bridging leaflet, you can see the outer septum usually here. And we can divide here or here. I don't know exactly, DORV or furrow is here. And so septation is coming from here.
I see.
And like a stitch like this. And septation is here. Maybe so we can divide the septum. So from left ostium to outlet to this one, maybe aortic, yeah. And after that, I don't know exactly, right side orifice is reasonable or not after septation.
I see.
That's a very important thing.
So maybe the question from me would be like, if I do echo
Yes.
and I saw this, how can I tell you echocardiographically, or I don't know what kind of imaging, that this is feasible for, biventricular repair or not?
Yes, sir, we can do by echo. So usually we have to confirm the left lateral leaflet size.
Left lateral leaflet height?
Size.
Size.
Breadth.
I see. Okay.
And so all the area of the atrioventricular valve. And if all the area of the atrioventricular valve is large, the possibility will be higher.
So I think if
Yeah.
I add a little bit, here, that you can open the left ventricle.
Left ventricle, yeah. This one is left ventricle.
So you have your,
Yeah.
well spaced the two papillary muscles here.
Yes.
That is a very, very important finding, telling that the mural leaflet is large enough.
Yeah, you're right.
So in echocardiographic finding, as far as I understand, the size of the left and right ventricle, balanced or not, is the one of the most important thing. In this case, that ventricle is reasonably well balanced. And the other is that the distance between the anterior and posterior papillary muscle of the left ventricle that is wide apart, which means that the lateral mural leaflet is large enough. So in this case, that what I saw in the below from the floor was that if you divide the common AV orifice into two, the anterior breaching leaflet and posterior breaching leaflet and lateral mural leaflets have quite equal size, which is a favorable finding for division. Is correct?
Yeah, maybe so. And so this one is no. So no pulmonary artery bonding or not?
No, no.
And
There's a
this
PS.
age, this size, without bonding the pulmonary hypertension, maybe.
Yeah, but you know, when I have a look on this specimen, it looks PA is not dilated at all and looks very thin. So I'm very curious. So when I saw the pulmonary valve, it looks as if it's bicuspid. Pulmonary valve.
I'd like to add some clinical information.
Yeah.
The original pulmonary artery was very small, so there was a BT shunt, and
then they put the
now
BT
it
shunt.
became very big.
Is
And
that so?
yeah, pulmonary valve
Yeah.
is bicuspid, subpulmonary stenosis, so it's a kind of AVSD tetralogy phylomorphology. Pulmonary artery
So there is a bicuspid
grown up. So now
pulmonary
it's
valve.
time for surgeon to divide the valve. Great.
So together with no pulmonary hypertension, so maximum is 1 1/2. That's